What's up, everybody, and welcome to this week's episode of the Well Man's Podcast. My name is Brian Brosey. I'm joined by my friend and co-host, Keone Tita. And today we're joined by Dr. Eric Chaconas. Dr. Eric Chaconas is a physical therapist and educator. He teaches extremity orthopedics with an emphasis on exercise prescription and manual therapy. He is an associate professor at the University of St. Augustine with research interests primarily focused on the rehabilitation of the shoulder and the knee. Eric also serves as the Florida Physical Therapy Association as chair of the research committee, and he provides continuing education for physical therapists via the Institute of Clinical Excellence. Dr. Chaconas, thank you for joining the show.
Yeah, thank you.
Thanks for having me.
Yeah, so we want to talk really some shoulder health and help people understand how they can train their shoulders well and fully, and also be healthy while doing it. So first off, I want to know what sparked your interest in the shoulder and how did you begin to kind of dive into it? Because for people who don't know, you have a few published studies regarding shoulder rehabilitation following certain, like a rotator cuff tear. I'm not sure. Maybe you can talk about that a little bit.
Yeah, we looked at people that had rotator cuff tendinopathy, or what some people might have heard of, rotator cuff tendonitis. And we looked at different exercise programs to see kind of which ones were most effective in helping them recover. My early interest in the shoulder really was sparked by my first position out of physical therapy school. I worked in a clinic that was right next door to the surgeon for the Baltimore Orioles. And so obviously he saw tons and tons of shoulders and was a shoulder expert. And he was just such a good mentor for me, and we kind of really hit it off. And so because of that, I just saw lots and lots of shoulders.
Okay.
And it became kind of one interest area. I'm a little scattered in my interest areas though, but yeah, the research stuff, I mean, it kind of, fell into my lap a little bit. Same thing I had at the Ph.D. program I was at. My mentor, that was his line of research. And so you kind of end up sort of, tacking onto that when you're a student.
Yeah, absolutely. Okay. So did you have the chance to work with a lot of athletes?
Yeah, I've seen, a mixed. I would say the majority of my career I've worked with like weekend warrior and kind of just your average adult with shoulder pain. A lot of I've seen so much rotator cuff injuries throughout my career. But as well as like frozen shoulder and instability. I have worked with, athletes, those are the ones you'll see quite a bit of shoulder instability, right? They'll dislocate their shoulder, and that's a totally different rehab approach.
Yeah, absolutely. Okay. So with the average person, what kind of shoulder myths or things about training? Like I've heard you shouldn't overhead press, things like that, things that put your shoulder in danger. What myths have you heard and that you kind of disagree with?
Yeah, that's an important topic. I'm glad you guys are asking that question. I think because I've heard so many of those, in my life, people say you shouldn't overhead press, you shouldn't behind the neck press, right? Yeah. I hear that one a lot. You shouldn't do an upright row, right? An upright row is a bad exercise for your shoulders. And I don't think any of that is true in a blanket statement format like that, right? So it's going to depend on the individual. For a lot of us, behind the neck press feels great, and it's a wonderful exercise, and it helps our shoulders feel strong and healthy. For me, that's the case. I behind the neck press a lot, and I still do it now at the age of 40, and it feels amazing. I love it. It's like one of my favorite shoulder exercises. So, but if you're somebody that maybe has had shoulder injuries in the past, maybe that doesn't feel so good for you, and so. If an exercise is painful, you really do need to get it looked at. You need to probably modify some things, or potentially there's a better option. But to blanketly, the idea with behind the neck press is it puts your shoulder in a position where it's kind of being stretched. The front of the shoulder is being stretched. That can be harmful for somebody that's had a dislocation. The upright row, maybe they say, well, it'll put stress through your rotator cuff. But, stress through your rotator cuff is a good thing. Right? That's what keeps your rotator cuff strong. Right. If you're having pain with an upright row, then avoid it. But if it feels good, then I think, it could potentially be a very good exercise for somebody.
So the first myth is basically that there are bad exercises, when inherently there's no bad exercise. It really depends on how that exercise affects you and how it works for you.
Exactly. There's no, in my opinion, there's no such thing as a good exercise or a bad exercise. It's all individualized, and it all depends on your particular situation. Um, the second myth that I think is really important is that to get big shoulders, you need to lift heavy. We used to think that. We used to think you had to press, overhead press, heavy weights to create shoulder girth and to get hypertrophy. And that's been dispelled in the last few years with a lot of really high quality research that has looked at lighter load training, going to failure. So high repetition. For example, let's say a set of 30, a set of 40, but you're going to failure. You're pushing until you literally cannot do another rep. So that level of intensity has been shown to also create a lot of hypertrophy, almost equal to the heavy lifting scenario. So anyway, I think that's really interesting when you look at a lot of the work that like Brad Schoenfeld is doing, the group out of Canada, the Morton group out of Canada, they're all kind of dispelling this heavy load myth, which is kind of neat.
And do you think that's specific to the shoulder, or we can kind of transfer that research to all the other muscle groups or muscles in particular?
Yeah, it's not specific to the shoulder. That's a good point. My understanding of it is they are looking at really whole body exercises, a lot of different exercises. By no means is that unique to the shoulder. But they have included, I know the one study, they did include overhead pressing, bench press, leg press. So it's a lot of kind of compound, large muscle, movements.
Yeah, okay. I'll have to check that out.
Dr. Chaconas, so do you know what the mechanism of that is between reps and just going heavy as far as like the hormonal cascade that's going on with that?
Yeah, the theory before was you had more hormonal release when you lifted heavy, right? That there was a change in the hormonal release. And the Morton study actually kind of disproved that because both groups, they had one group that lifted very heavy, one group that had a lighter load, but both went to failure. That's the important variable. They're both going to failure. It seems like going to failure is kind of the key variable, more so than the load. And they didn't have a huge difference in the hormonal markers that they tested. So that's kind of interesting.
Yeah.
The heavy load group does get stronger, but when you look at hypertrophy, if hypertrophy is the goal, that seems to not be as significant of a difference.
Seems like you would get more volume with the group that's increasing in hypertrophy if they're doing much more reps and at a lighter weight.
Right. So time under tension is an important variable, right? You think about how that feels. When you do a high repetition set, the pump that you get from that is pretty significant. I personally, don't feel like if all I do is lift heavy, I don't feel the same amount of pump in that muscle that I do when I go to failure with a lightweight. I think the answer to this really is mixing it up, right? Yeah. I think you probably want to integrate both high and low rep sets, but going to failure is critical.
Yeah, I would agree with you. Do you know who Jeff Cavalier is? Athlean X on YouTube. He's a physical therapist. I was just in thinking about the shoulder and preparing for the podcast. I watched a couple videos he has about shoulder training. And he was saying that he thinks the shoulder group is the most understretched muscle in the body. And you spoke about really liking the behind the neck press because you get that anterior delt deep stretch in there. How do you feel about kind of that, just what he said there, with stretching being important to the shoulder, maybe being one of the most understretched areas of our body? And do you think it needs more stretching in our health routines?
Yeah, I've never thought of it that way. First of all, he puts out quality content. I really do appreciate the work that he does. So I like to integrate. I think if you integrate one exercise in a full lengthened position in each of your routines, I think that has some value to it. Mm-hmm. For example, on bicep, when we're training biceps, I like people to do an incline bicep curl. So you're laying back on the incline bench. Your shoulder then is falling behind you into extension. And so when you go to the bottom of that movement, you get a full length stretch through your biceps. It feels really good. It's a nice stretch. It stretches out the fascia, stretches out that muscle tissue. The next day, you're going to feel a little more sore when you integrate that exercise. It's a good point. I never thought of it until you said it just now. When you train, when I train shoulders, I don't always feel sore the next day. And partly it might be because I'm not getting in that full stretch position. So You might be right. Maybe that's why we like the behind the neck press. That certainly puts you in more of a stretch position than the other shoulder exercises. I do think it's important to mix those types of exercises into a routine.
Yeah, absolutely. So what are some of the, if any, of the other myths around shoulder training that you've come across?
Well, back to that bad exercise topic, I just think the idea that something is going to cause an injury or a tear, don't do that. That'll tear your rotator cuff, that type of stuff. We don't know of any exercises in the literature that actually cause specific injuries. That I'm unaware of that. What seems to be associated with rotator cuff tears are more health-related behaviors. Smoking has a correlation with rotator cuff tears. So maybe there's a tissue healing factor. Side sleeping, although it's challenging and you hate to mess with somebody's sleeping posture if they feel good and they're sleeping good. But generally speaking, perhaps if you have shoulder pain, maybe sleeping on that shoulder isn't the best thing. Overall weight, right? Looking at BMI. So anyway, exercise is healthy. Doesn't matter how you do it. As long as you're doing it, your shoulders are feeling good. Don't let anybody tell you that anything's going to damage your shoulders. Yeah.
Okay. And so there's not a specific position that you try to avoid or anything like that throughout your training. You want to hit the whole, because, the shoulder has such freedom of movement. You really want to take advantage of that freedom safely through your training. Really be diligent.
Yeah, we can talk about
types of motions and things like that.
That's what I think. We can talk about muscle imbalances, and muscle imbalances are another topic where if you look at somebody's overall program, their mix of pushing to pulling exercises, the way that they periodize their body parts, maybe somebody is a little bit chest dominant and they focus on their chest so much and they don't do enough back work, and perhaps that maybe leads them to shoulder injury. That has been looked at a little bit, but generally speaking, from an exercise standpoint, there's nothing that I think you need to avoid.
Mm-hmm. Okay. And then in a warm up for like a shoulder routine, if you're going to do shoulders that day or really hit them hard, what type of things do you want to consider when programming a warm up for someone like this, or just when, safely putting them under the bar in the future?
Yeah, I guess it depends on the program and what you're doing that day and the goals of that day.
Of course.
Warm-ups are a good thing, right? Warm-ups, it's nice just to kind of get to ease into the movements, into the workout. So I've seen people do like rotator cuff exercises as a warm-up. So you're standing and you're working in external rotation of your shoulder or internal rotation. You're basically rotating your shoulder with a band or with a dumbbell to sort of warm up. And that can make some sense. My only concern with that is maybe you're going to fatigue your rotator cuff because you're doing so much isolated rotator cuff work before you say press or front raise or lateral raise or something like that. And maybe that's not what you want. I think you just want just enough. I guess for me, the warm up is just enough to wake everything up, wake the nervous system up, get us ready to go, get some blood in that muscle tissue so you're feeling a pump and you're ready to go. But not to a point where you're so fatigued that you're going to change your movement patterns.
Yeah, absolutely.
Is that where you think most of the injuries come from in lifting with shoulders? Is that maybe they're going too heavy too fast, or they're pushing through the fatigue or pain?
Yes, I think that's spot on. But a lot of the ones I get, it was the last set of the day. Right.
Yeah.
Or a lot of the high intensity interval work, which I love because the cardiovascular benefits of that are tremendous. And you can't match that intensity with a lot of other forms of exercise. But at the same time, if we are doing kipping pull-ups at the end of a mile run and then we're going to overhead press, you know what I mean? It's just they're just so tired and form gets really, really sloppy and it's a weight they can't handle. And maybe it results in injury. But even then, I still think those numbers are pretty low, and that's anecdotal. But you don't hear of that scenario that frequently. It's probably more the last one that you said, Keone, and that is they're pushing through pain. So you begin to tweak your shoulder, you feel a little pain, you kind of keep pushing through it. And here you are a month later, you haven't adapted your program, you're still pushing through it, and you're having pain, and that's probably what leads to the injury.
Yeah. Okay. Yeah, I mean, it makes sense. It's like it's common sense in a way, right? It's like if you're doing an exercise that's creating pain, then switch it up, do something else. Don't be rigid in your exercise views, so to speak.
Exactly. It's very much common sense. Listen to your body. When something isn't right, seek the help of a professional. But it is very much common sense, yes.
So on the flip. Go ahead.
Go ahead, Brian. Go ahead.
On the flip side of that, what about popping, clicking, all those types of things with no pain? What do you tell an individual who may be doing a bench press and, they have the popping or a clicking type thing in their shoulder, but it is not causing pain? Is that something the person needs to drop that exercise, figure out something else, or where do they go from there?
Yeah, I mean, the consensus on that is that if you have joint noise, we call it crepitus, that if it is asymptomatic and not painful, you don't need to worry. That being said, if I'm doing a movement and every single repetition I feel the same snap or click or pop, probably need to change something up. Something's moving, probably in a healthy way, right? It's probably not necessarily damaging, but, do I really want to keep pushing through that? That's a situation where I wouldn't necessarily go seek the help of a professional. I wouldn't get my shoulder looked at, but I would probably try to change that movement. Maybe it's the angle of the shoulder. Maybe it's the load. Maybe, it's just the way you're doing it. See if you tweak your form, if you can get it to go away.
Yeah. Okay.
What's actually going on? What's actually going on in the joint space with that? I mean, what is the range of things that can be going on in the joint space? Like I'm thinking, like are labrum tears kind of happening there or not?
Could be. It could be one of multiple things. One is oftentimes you feel the top of your rotator cuff, the top muscle, you feel that rub against the bone that's above it, or you feel it rub and snap on the kind of adjacent side of the joint. You can feel labrum tears as popping and clicking. That is a common symptom of labrum tears. And so the labrum, when you look at the shoulder, is kind of like the suction cup. It's the cartilage around the socket side of the shoulder joint, and that gets torn. And then what you end up having is that cartilage will snap and move inside the joint. Yeah. That's usually, in somebody that's had a shoulder dislocation or an overhead throwing athlete, they are susceptible to labrum tears, baseball players, stuff like that. That's kind of an extreme cause of clicking and popping, and you would feel it deep in the shoulder and it wouldn't go away. It would kind of pretty much be doing it more or less all the time with many different shoulder movements. The other thing is, as we age, some people, we do get a little bit of age-related changes in the shoulder joint. So maybe you have a little bit of cartilage wear and tear, osteoarthritis. That's normal. That's a normal part of the aging process, and that'll definitely give you clicking and popping as well.
Right. With the labrum tear, is that something – I guess it depends on how bad the tear is, but is that something that you can get over and recuperate from, or is that – I always think of cartilage as not being very vascular, so it's hard for it to heal. But, I mean, I've also heard – and I don't know if it's a myth or not. I've actually heard some surgeons say, like, once you get a labrum tear, that's it. You're going to eventually get a shoulder surgery, or you're going to need it.
The labrum, so it can scar down. So you have different severities of labrum tear. That's really important. And if you look at the first four types of labrum tears, type 1, 2, 3, 4, we all are walking around with a type 1. So a type 1 labrum tear is fraying. So you think of fraying, a little bit of wear and tear on that cartilage. That's a normal part of the aging process, and that happens to all of us. And most of us are walking around with no shoulder pain whatsoever. But if you did a scope, if you arthroscopically looked at our shoulder, you stuck a camera in the shoulder to look at it, you'd see that fraying. Yeah. Now, people that have traumatic labrum tears, they dislocate their shoulder, they fall, they get hit, something happens, they dislocate, they get that labrum tear. If it only happened one time, those patients tend to do well. If they're in a sling for a period of time, they will heal. They can rehabilitate. They'll go to physical therapy and they'll do well. Once it starts happening again and again, so remember Mel Gibson in the movie, I forget the movie now, when he dislocates his shoulder to get out of the
yes.
I always think of that when I think of this. But
right.
So that's the person that's dislocated their shoulder multiple times, 3,
Right.
4, 5, 6, 10 times. That's what you're talking about. That person probably is going to need to get it repaired to restore the stability of that shoulder.
Okay.
But a lot of people can also rehabilitate. If we get the muscles around the shoulder girdle really strong, they can compensate for that instability, and those patients can avoid surgery as well.
Yeah. So again, going back to like weight training and stuff, and make stronger other parts of the shoulder joint itself.
Yep.
To compensate. Yeah, that's an interesting thought. I never thought about that.
I can't tell you how many people I work with that have labrum tears that are lifting and doing great and doing, it's like one of those things where you get it diagnosed when you're young because you had a shoulder injury, and over time it tends to feel a lot better and they end up functioning perfectly fine with no surgery.
Yeah, that's great. You said another interesting thing, and it's always fascinating to me when I get like an imaging report on somebody's spine, shoulder, whatever joint, and I always see, degenerative change. It's it's always there. It's just a part of being on the planet, right? I mean, it's not. Some people, and it makes me laugh because I remember when I was I don't know, I think I was in my 30s at the time, and I went to a chiropractor and they took an image of my spine, and he looked at my spine and said, "Oh, you have the spine of like an 80-year-old." And I was like, "Well, I have no pain. I feel fine. I feel fine." But for the lay person, when they hear that, it kind of puts them in stress mode. They're panicked a little bit, but it's just part of being on the planet then is what I'm hearing you saying.
Absolutely. And that is horrible. That is malpractice. The things that
Right.
we say to patients are so critical. And when we put these, we call them thought viruses, right? We put these thought viruses in people's minds and they read the report, their imaging report. It is incredibly damaging psychologically.
Right.
It is normal. If you were to MRI 100 people over the age of 60, more than half of them would have a rotator cuff tear. People with no shoulder pain.
Right.
If you take men ages 40 to 70, and you MRI them. These are men with no shoulder pain whatsoever, functioning, feeling great, no problems, right? You MRI their shoulder, over half of them are going to have a rotator cuff tear. Most of them are going to have AC joint degeneration, AC joint changes. A large proportion of them are going to have labrum tears and bursitis.
Mm-hmm.
Those pathologies are normal parts of the aging process. Now, when you have that injury and you have significant pain, and you go in and get an MRI, well, that's not what you'd expect, right? That's not normal. But when you're feeling good, and you look at some of these shoulders that have these pathologies, that's normal. We call it wrinkles on the inside, right? It's like gray hair. You expect it. It's coming. Right. And it's just staying fit and healthy. Don't let it get in your head. Keep moving.
Uh-huh. It's another thing that fascinated me, and I don't know if this is true. Maybe you could answer this for me. But I think I can't remember. I think I read this, and Brian and I talked about it. I think I read this in the Merck manual, the Bible of the medical student. But it's reading about osteoarthritis, and they're saying all mammals that live on this planet get it, with the exception of mammals that hang upside down, like bats and sloths. Do you have anything to say on that? That's fascinating to me. I don't know. So that tells me that gravity is playing a part in these, these changes in our skeletal structure, if that is true.
It could be. It could be. I mean, it's a loading. When we think of osteoarthritis, we think of loading. So you think of compression on the joint. Yeah. And that does make sense in that regard. But what we've seen recently, when you start looking at the osteoarthritis literature, it's more associated with a sedentary lifestyle. So we used to say, oh man, running is bad for your joints. Well, that's really not accurate or a good thing to say. But people used to say that. You used to hear a lot of people say that, right? Running and the pounding on the pavement.
Right.
It's actually protective of osteoarthritis. When you look at runners in the long term, they actually have a less osteoarthritis than sedentary people. So the things that tend to cause osteoarthritis or associated with osteoarthritis that we know nowadays, sedentary lifestyle, unhealthy so diet is critical. It's a low-grade inflammatory condition, and so a high-sugar diet, these diets that are pro-inflammatory, they tend to probably be more causative than osteoarthritis than anything else. So yeah, it's just overall health that's critical.
Right. So that's a myth you're talking about. So these people who are runners, it may be something, or at least something else going on than constantly pounding the pavement, or training too much, not giving your body plenty of rest between training sessions, maybe over time.
Yeah, I think when you're pushing it too hard and you're having injuries, that's when problems can occur.
Yeah.
It goes back to listening to your body. But generally speaking, the more active you are, the more fit and healthy you are, the more you're running and doing all these things, the less likely you are to have these different musculoskeletal conditions. You still always see people say, like, I'd rather see an orthopedic surgeon when I'm old than a cardiologist. You really shouldn't be seeing either one of them if you're doing it right.
That's right. Well, and what you're really saying there, if you want to do something to slow down the aging process, move, right? You just move your body.
Exactly.
Yeah.
So have you given people instruction to essentially dead hang from a bar and kind of distract the shoulder to help kind of keep their shoulder healthy, maybe after a lifting session or anything like that?
I like that. It feels good. I do that myself sometimes. I haven't used it a ton in practice. It is a nice stretch. Feels good on your lats. It feels good on your upper back. You're not, because you're having to grip the bar and your muscles are engaged. So you're not like totally stretching out the joint. It's probably more of just a lengthening movement. But yeah, if it feels good for you, for sure, that's a great one.
So we were talking about muscle imbalances earlier, and how can someone, first off, at home, if they're sitting there listening to this podcast, how can they become aware that they have a muscle imbalance? And kind of one of my go-tos, and I want to see what you think of this, is if someone's standing there and they just drop their arms right by their side, their thumbs should not be pointing at each other. So their arms would be like internally rotated, and their hands would basically be lying where their pockets are in the front, as opposed to right beside them, kind of at the hip level, with the thumbs facing forward as opposed to facing each other. So do you have anything where someone listening could basically assess their posture and maybe find out that, hey, I do indeed have a muscular imbalance where maybe I'm doing too much pressing or something like that, and I need to change this to keep the health of my shoulder?
Yeah, that's a nice way to look at posture, right? Just shoulder position from a postural standpoint. I think taking pictures of yourself, right, at every angle and trying to look at your imbalances. I think we can take a lot from bodybuilding when you look at, symmetry and an aesthetic standpoint. I'm really interested in aesthetics for lifting weights. I know a lot of people are like, oh, that's vain. I think deep down inside, we all want to look good, and we're lying to ourselves if we think we're only exercising for the health benefits or for some other benefit. We want to look good.
Yeah, it's like the Trojan horse of our profession, I feel like. It's like the vanity aspect. We bring the vanity aspect, and through that you find wellness.
But just embrace it. There's nothing wrong with looking good, wanting to look good. That's critical. So embrace it. And
most of all, be honest with yourself, too.
Absolutely.
Yeah.
But I think you do want symmetry. You want, I always think it doesn't look great when your kind of back is very rounded because your chest is so dominant. It's pulling your shoulders forward. That is theorized to cause shoulder pain. And it does make sense. And I have seen that a little bit. I've seen people that have that type of imbalance and do have a lot of AC joint issues and rotator cuff issues. So you certainly want to, I think one thing that I would say, if there's one thing I change more frequently than anything in somebody's routine, it's that I give them a little more back work, a little more pulling work, a little more scapula focused kind of control type work. Mm-hmm. So from a visual standpoint, that's one way. I think also just looking at your strength, right? If you're benching a good amount of weight, but you can barely do 5 pull-ups, that's an imbalance,
Okay. So you can assess it many ways through
to do it right, to really, and I don't know that muscle imbalance is all that critical of a thing to look at, but to do it right, you got to force test all those muscles. Having another person, obviously, with some equipment, force test you.
Okay.
And what do you mean? What do you mean by force test? I mean, is that something that somebody would go to a PT to get done?
Yeah, but you'd have to have a PT that actually tests muscle strength objectively. So the problem with our profession, a lot of us will we will do something called a manual muscle test, which is just us feeling how strong you are by pushing against you, which is a terrible test to measure strength objectively. Yeah. There are dynamometers, though. A lot of PTs use dynamometers. So it's like a thing that you hold in your hand, and it's just going to measure pounds of force, right? And so they can test you by having you isometrically push against that. And then in your really fancy settings, there are isokinetic devices that'll measure strength throughout the range of motion. I do want to plug, I have no financial interest in this company, but there is a new device out there that's really cheap, Active Body. Active Body is a force testing device that you could actually do at home on your own if you wanted to. But again, I don't know that it's worth your time and money to do that. But if you're interested in force testing, they make a nice cheap dynamometer that's just hit the market that's like a tenth of the price of everything else that's out there.
Wow, cool. That's great. Great info.
So I think a lot of people have a hard time understanding when you're talking shoulder health, you're really not just talking the shoulder. You really got to consider the scapula and then all the muscles that are attaching on the scapula from the back. And then in turn there, the back muscles, or the back in general, the cervical spine, the thoracic spine, and how can an individual, basically, I guess when they're setting themselves up for like an overhead press or a bench press or something like that, how should they be aligned in those areas to go through the healthiest range of motion possible?
So I think a lot of it is guided by, so in other words, your scapula, right? They're going to move based on the position of your elbows and the direction that you push the bar. So a lot of it is guided by actually technique. And I think cueing people from a technique standpoint is a little more effective than telling them like tuck your shoulder blades back or move your shoulder. So when I have people move a certain region of their body in a certain way, I find it's challenging for them compared to if I give them a specific technique cue, right? Like pull your elbows forward or something like that.
Okay.
So in other words, you're creating what you're getting after via proxy, a technique cue on bar position or elbow position or forearm position or some other movement pattern like that. But generally speaking, yes, it's all connected, and spine position is critical. Spine position matters. Having a nice upright thoracic spine, right? If we're flexed forward or hunched forward, we're certainly going to have a harder time moving that weight. Neck position is critical. So looking at the position of your neck, where are your eyes looking, what's the direction that your eyes are moving in, where's your chin located, because that'll all influence your spine position.
Yeah. Well, I think the cueing is great because even in personal training and in the small clinic experience I've had so far, I've had a lot of trouble, because these people haven't moved like this before, and you really have to develop the dissociation between the humerus, the arm bone, and the scapula. If I'm just trying to get someone to move their scapula and keep the humerus in place or something like that, what ways have you found useful in basically teaching someone that dissociation and developing them? And I can tell, obviously one of them is those cues that you just gave us.
Yeah, but then in addition to that, I think breaking it down into different sort of like sub exercises or isolated exercises. So for instance, scapula control for me, and the most effective one is if I can get my hands on their scapula and kind of guide it manually, because then they feel it, right? They feel it, the movement pattern. But for people that are just kind of listening at home, I think just, generally moving your scapula in isolation by themselves before you do the movement. So in other words, shrugging your shoulders, right? Shrugging your shoulders is elevating your scapula. bringing your shoulders back, drawing your shoulder blades back and squeezing them between together, bringing them back and then down. So squeezing them together and then drawing them down towards the ground like you're trying to elongate your neck. You're trying to stretch your upper trapezius leg, bringing them forward. So that's kind of like a nice way to sort of isolate your shoulder blades. And then the overall movement pattern tends to get a little easier because you feel that shoulder blade control.
Mm-hmm. Okay. So, and do you have a specific way that you do that with people? Like, do you put them kind of in a prone position, or do you have them seated? Is there a way that you found that's a little bit more effective just for those who really have not moved in that way?
So when somebody has an injured shoulder and I'm working with them, rehabilitating them, I've got them in sideline with the injured shoulder up towards the ceiling. And I have my hands on the shoulder blade and I passively guide it into all these different positions. Because one thing that does happen with shoulder pain and shoulder injury is you'll get scapula dyskinesia. So the dyskinesia is like the inability to move the way that you want to, or, this normal voluntary movement. And so they won't really know where their shoulder blade is. They don't have that good mind-muscle connection, right? And so you're trying to kind of restore that. The hands-on approach, the tactile cueing that you're giving them by touching the shoulder blade really helps a lot. And then I can kind of find out what places they're struggling with and guide them into those positions and have them move. And then I have them resist against me and do like that. And then from there, then we start kind of doing some more weightlifting type movements and exercises.
Okay. Anything else, Keone, do you have any specific questions?
Well, I mean, I'm sitting here listening to this and I'm just fascinated. I'm just thinking about our healthcare system from a global aspect. And I how many people have like shoulder issues that really that go to their medical doctor. I'm not beating up medical doctors here, but go to their medical doctor and their medical doctor will treat them with NSAIDs or steroids without really looking at the functional patterns or movements, which is really going to get to a true, cure for them, so to speak. Mm-hmm. It's almost like the gateway keeper for most musculoskeletal injuries is the PT person and not the medical doctor, So it just, and I think some of these treatments, especially the injections that I see with a lot of my patients that come in, it's like, it seems like they have the potential to damage the joint even more. So I'm talking about, like repeated steroid injections. Any thoughts on that from either one of you?
Yeah, I mean, anytime you and this is I took a course in diagnostic ultrasound with a radiologist a couple months ago, and his quote, this is a radiologist that injects joints an interventional radiologist injects joints all the time, and he said, anything you put in a joint is potentially damaging to that joint. Yeah. It's not normal, it's not natural, it's not healthy. I'm only injecting things in joints when I have to, right? Yeah. So from his perspective, it was like people that have pretty severe pain. He has to relieve their pain, right? Right. You're absolutely right. Repeated cortisone injections, that deteriorates tissue, right? It deteriorates collagen tissue. And so that puts that person more susceptible to tendon tears and stuff like that later in life. We really want people to know that these bumps and bruises are normal, that you oftentimes will get through it on your own. Wait and see. There's a lot of benefit to the wait and see approach, right? If I have shoulder pain, it's probably going to go away in a couple of weeks. I'll probably be fine. If it persists, I need to go and get it looked at. But I probably need to try exercise first, healthy interventions first, and don't rush into surgery. A very low percentage of people will access a physical therapist. It's typically about 10% of people that have musculoskeletal pain will access a physical therapist. And that's obviously our mission, right, is to advocate for more people to go directly to the PT, avoid surgery, avoid drugs, that type of thing. Yeah.
While we're on kind of this topic, the sling we know is not necessarily the best for rehabbing the shoulder, just allowing the shoulder to heal well. Can you speak on that a little bit?
Yeah, I haven't, in my experience, haven't seen an overutilization of slings, so I don't know that it's necessarily problematic. But
I'm also talking the positioning.
I know, holding it against your body. So yeah, there's some debate about that. And mostly what you'll see is in the labrum tear population, right? Should you have the sling right up against your body, or is there one of those big pad pillows holding you out in neutral? I haven't studied that topic lately, but when the last time that I did, I do remember seeing there was some benefit to having that pillow there. The shoulder's more in a neutral position that gives the labrum more of a neutral position to lift or to heal in. That's been looked at a lot, though. And I know that literature is hotly debated, which is better. But yeah, a surgeon, a good orthopedic surgeon should know the answer to that. I would think if somebody was recovering from a labrum tear, which sling is going to be optimal.
Now, if someone's experiencing shoulder pain today as they're bench pressing, and this is the first time they've experienced it, after that, and they go home, should they put on a sling for a day or two, or should they ice and not put it in a sling, let it be natural?
I don't think they should wear a sling in that scenario. I mean, it's hard without knowing the person and exactly what's going on. But generally speaking, slings are helpful when we know immobilization, right? Immobilization is critical for that shoulder to heal. If I have rotator cuff related pain, tendonitis, something like that, that's not a sling's going to actually probably be harmful, right? Because everything's going to get weak and we're going to start to tighten up. But if I have a labrum tear, that's when maybe a sling is helpful. So I've had a lot of patients that tore their labrum and avoided surgery because they just wore a sling for about a month, couple of weeks, and then we rehabbed them, and they did great. And it's that early immobilization that helped them heal and recover. But that's a pretty extreme injury. Yeah,
and would you put them in that sling in that neutral position that you were referencing earlier with the pillow?
Yeah,
for that specific
in my experience, I haven't been able to dictate it. So
Gotcha.
The ones that I'm thinking of, they dislocated, they went to the ER, they saw a surgeon, they opted not to get surgery, but in the surgeon's office, they got the sling. I've never prescribed a sling. I've given out a few slings here and there, but they're just like the free ones that we happen to have in the clinic, the cheap ones that don't have that pillow that you're talking about. Usually it's a trauma case and they've seen another medical provider before coming to us.
How can someone make the smart decision of, I will go ahead with this surgery in like a labral tear case?
Yeah, that's tricky. It's a lot of it is their goal and their outcome. So you've got a baseball player in college, that he's got a limited time span of that career. Surgery is going to get him back faster. He's probably going to be able to perform at the prior level much quicker. I think it's when we get into the population where our goals are just to stay healthy, to stay fit. The labrum one is an easier conversation to have because if you're having instability, you need to get the surgery. If your shoulder is feeling okay and it's not dislocating regularly, you don't need to get the surgery.
Okay.
The challenging conversation is the rotator cuff tear conversation because that's a bit of a crapshoot. A lot of people, when we look at rotator cuff tears long-term, there's no difference long-term outcome surgery versus conservative management. That is really, really important. And I will send you guys any of these studies. You can maybe link them somewhere because it's really important for the public to know that. Wait and see, looking at outcomes 1 year, 2 years later, exercise versus surgery, no difference when we look at rotator cuff tears, rotator cuff tendinopathy, and stuff like that. So that conversation is a little more challenging. However, some of those patients do benefit from surgery and they do need surgery. So I think it's probably case by case. How are you functioning? How much are you seeing any improvements whatsoever over the course of a couple weeks, or are you getting worse? Right. Getting worse, maybe I'd go see a surgeon in that case. But
okay. Well, I'd love to get those studies and I could digest them and make a podcast solely about that. I think that's a fantastic topic. Like you're saying, everyone needs to be well educated on. Is there anything we kind of brushed under the rug or didn't mention, Dr. Chaconas, that you feel like we should?
Well, just on that last point, I want to plug, you could do a whole thing on surgery versus conservative management for shoulder pain, for age-related knee pain, degenerative meniscus tears. That's another one where you got some really interesting studies where they knock people out put the little incision in the knee, but didn't actually do anything, right? Just a little incision. So you wake up, you got an incision, like, surgery went great, everything's wonderful, but didn't actually do anything. And there's no difference in that group versus the group that gets their knee scoped. So arthroscopic clean out of the knee for a degenerative meniscus tear. This is this is somebody that's probably over 40. There's no difference when you look at that versus placebo or sham versus exercise therapy. And then back pain. You could do 10 episodes on back pain.
Yeah, I definitely want you back on to talk about back pain and knee pain.
I got a better guy. I got a good guy for back pain.
Okay, that'd be great. Man, thanks so much. That incredible stuff, man. I really learned a hell of a lot. I know the people out there listening will too.
Awesome. Thank you, guys.
I deal with a lot of shoulder pain with just acupuncture. It's just pain management. So it's nice to have this info to tell people, because I really have people who are really stressed out about certain things where they may not need to be.
Absolutely. And the best thing that you can do as a clinician is just reassuring them it's going to be okay. Your shoulder's going to heal. You're going to be fine.
Yeah.
We recover. The human body's made to heal and recover. And you don't, I think that's the biggest thing that I do is try to mitigate fear and anxiety.
Yeah, it's great. Which allows better healing doing that, right?
Absolutely.
Get rid of some of the stress, you heal better.
Yep, for sure.
Dr. Chaconas, where can people find you online, like PT on Ice, all that sort of stuff?
I am on Twitter at echaconas, ECHACONAS, and I'm on Facebook a lot. We do a PT on Ice daily show, so that's kind of a fun thing where every morning one of us goes on for 10-15 minutes and presents a topic relative to physical health and rehabilitation. It's very physical therapy slanted, and our target audience is more physical therapists, but I've had other people from other professions tell me that they enjoy the show. And so anyway, that's the PT on Ice daily show on Facebook.
Awesome. Okay. Well, thank you so much for joining us. I really appreciate it. This is awesome. And
it was. Thank you, Dr. Chaconas, man. That's great.
Thank you, guys.
Hope to have you back on soon.
Awesome.